All right, so I'm going to talk about anesthesia, and I use the term FUT. I know it's outdated. This is something it's in the course syllabus for a long time, but it's really linear strip excision. We haven't come up with an exact terminology, but everyone knows what it means. It means a strip. So I'm going to divide the principles into the types of anesthesia. There are ring blocks, there are tumescence, and there are nerve blocks. Those are the three categories you'll hear, and I use them very selectively for specific reasons. In general, for the anterior portion of the scalp, I use a ring block and I use nerve blocks. For the FUE harvest on the back and for beards, I use a field block or tumescence. That's the easiest way to think about the distribution. I have an accredited surgical facility which affords me the ability to give a little bit more. Most of you are not going to be able to give intravenous sedation due to maybe state regulatory guidelines, but it really helps a lot. So I'm going to give you some alternative methods to do this. You can obviously potentially do IM or other techniques as well. So these are just different methods of doing this. With FUE, I cannot give them true sedation. I give them a little bit of intravenous pain medication. They are a little bit sedated, but because they're in a prone position for a long time, I really can't get them too deep, and I usually pulse them with a little bit of Demerol if they're getting a little fidgety. And I can tell you during FUE cases, they can oftentimes get fidgety. Without that intravenous dose, sometimes it's harder. With strip procedures, I'm able to give them a much deeper level of sedation, and I only need it for the initial ring block because they're supine for most of it, and so they just sort of fall asleep by themselves. And once the ring block is in, it's much easier. So if you don't have that, I have no affiliation with any companies I'm mentioning. Nitrous gas is great. I don't use it, I don't need it, but if you are looking for something to add to the pain control, think about this. The patient's experience is so important. If they have an uncomfortable experience, they may not have a second procedure with you, and they're going to tell their friends it was painful. So really, comfort is so important. Vibration techniques. Our brain can only sense one thing, pain or vibration. The more vibration you can get, the better. If you can vibrate your fingers, if you can use vibration techniques as much as you can, try doing that. I use a little glove to protect it. My staff actually, even with them being under some sedation or under intravenous control, they still do this. So Steve gave some really good anatomy. I'm just going to reiterate points. You're going to hear a lot of redundancy this morning, and redundancy is the key to education. And we're going to actually go through each of these nerves, so don't try to memorize this guideline, but just understand that you need to memorize it after the fact because you need to know these nerves. So what do I do? So remember what I said, the key to the front is nerve blocks for me. The reason for this is in the past I would hold everything on that ring block and there would be breakthrough moments. In the middle of the case, they got to go back and put a little bit of anesthesia, and the patients hated it because they're more awake by that point. So now with these nerve blocks, I rarely have to come back in the room and give more numbing. They are blocked. The supraorbital nerve is in that little notch. The key when you give this nerve block is not to just start injecting. You must withdraw. You must make sure you're not in a vessel. It is so dangerous if you are not withdrawing. I inject half to 1 cc, and all you need to do is hit the supraorbital. The supratrochlear only anesthetizes this area. So I don't go medial. I don't try to hit this area. There's no reason to. You just go up and hit to block out this central zone. It does not hit the lateral hairline. And so for the lateral hairline, I've got to hit a auriculotemporal block, and that's going to be right here where it's the easiest place to understand it. It's if you look at the tragus, I usually use the tragus as a starting point. You'll feel a little dip in your ear right above the tragus. That little dip, palpable dip, it's right behind the supraorbital, superficial temporal artery. So please be careful where you're injecting. You cannot get this into the artery. So must withdraw. I think I've said that 85 times now. And then slowly inject. I actually constant withdraw as I go in with it just to make sure I'm good. This will get the lateral hairline, but not the temporal point. So that's just showing the injection there. The zygomatic temporal is the third block. These are the three blocks that you need to know. If you're doing a temporal point or you're doing a female hairline that goes lower, you're not going to get this with that auriculotemporal nerve block. So I inject this one. How do I do it? So what I do is I use that same 1/2 inch 30 gauge needle. I feel the lateral orbital at the canthal position, like you go from the canthus, go laterally. I palpate the edge of the bone, this bone right here, okay, the zygomatic bone right above it, and I go right, you can actually sometimes feel the suture. It's right at that zygomatic temporal suture. I go right underneath the bone, I skive it, right, going medially, directly medial, aiming it toward the eye, go right underneath that bone, always withdrawal. That's probably my 86th time I said this. Slowly inject, and you'll get that nerve pretty consistently. It's right under the bone, very superficial. I can show you this in lab or go through it with you again. So I palpate that lateral edge of that bone, I go right underneath it. Tumescence is the key. I'm filming this so you can look at this, but you can take photos of these things if you need to. But basically the difference, in summary, is I use a dilute lidocaine for my strip procedures. I do a dilute lidocaine with bupivacaine or marcaine for FUE donor and recipient areas. For the recipient, I just basically add some triamcinolone, 40 milligrams of hyperdilute in order to just minimize edema. You probably, if you don't know, Abbasi's come up with a great formula which minimizes postoperative edema. It's basically just adding some triamcinolone into your recipient area, and that can remarkably minimize it. I probably have about a 5% rate of edema around the eyes postoperatively because of this. So what I do, what I've changed over the years is my hand, I had a little bit of this little ganglion cyst. Now it's gone away, but that was great that I had that because I moved everything from 10 milliliter syringes down to 3 milliliter and 1 milliliter. So a lot less tension on the hand. I start with a 27 gauge to do my ring blocks, but I switch over to 25 gauge when the patient is anesthetized. So for bupivacaine and for tumescence, I use a 25 gauge with a 3 cc. You can use up to 5, but if you're young and healthy, do that. If you're old and decrepit like me, I would advise using smaller syringes. And it's actually less uncomfortable for the patient too. The smaller you use, there's less tension on it. This putting some recipient tumescence around that area as well. So let's talk about FUE, how I do donor anesthesia. So the first thing I do is anesthetize a few little punctate dots near the border of where the occipital nerves would sit, and that's along the mastoid prominence. If you don't know that, if you don't know where the mastoid prominence is, just come and feel the back. You'll feel that bone on the back. That's the mastoid. If you don't know during lab, I'd be happy to show you that. That's the basis of understanding. So I just put a few blebs with a 32 gauge needle because they're a little bit more awake at this time. Use some tumescence. This is with the very dilute bupivacaine. I start at the nerve. It's going to be a little uncomfortable for the patient, but I start at the nerve to really get that going laterally, sort of at the two mastoid points, and I just raise blebs. So I don't pass that needle through there because it's uncomfortable. I just raise a wheel and get that wheel elevated along the occipital nerve. And then I go around it. Testing. I go around it and I just continue to raise this wheel. So now I've got this big wheel around it. That's the nerves are blocked now, and from that I can arch upwards, and I can go out and finish with laterally. Once I've gotten that occipital nerve block, they're pretty good laterally. So as I inch laterally, they're not feeling too much. So this is an alternative method that I've been using that I like. Let's see if it will play. Oh, actually, you can't hear anything. I'm sorry. Hey, I forgot. Can you see if you can hook this sound up? I can narrate this. Is Douglas there? So basically what I've been using is a pressure bag and with a long 21 gauge spinal needle. And the reason I love this is it, again, further takes down pressure off my finger. And so by having to even inject with 5 or 3 milliliter syringes, it gets fatiguing on the hand, even with a 23 gauge needle. So by doing a pressure bag, I pressure it all the way up to the maximal red line on there. And it's the same tumescence that I showed you before, but it's in a bag. I'll just narrate this. And so then what I do is the same thing you just saw. I'm going to take that, I go ahead and first anesthetize these little areas, raise little blebs along the marking points that I showed you. I like to go along these pre-lined squares for the FUE harvest because that way I don't have to mark out additional dots. Sometimes I'll make little dots between the actual squares for additional, in case I want to add additional anesthesia. Again, what you want is them not to feel the entry point of the needle going in. And so since I'm using a very large spinal gauge needle, I don't like them to feel that entry. So I use a 32 gauge needle to start, or 30 gauge needle, and then I just release that clamp, and now it just fills up like a tank of gas. It just fills up, and I just let it sit there for a while until it just starts ballooning up. before I start to inch it out. And as I inch it out, I start inching medially, and then I start to inch down, and I start to inch laterally. And by really filling up that corner where the mastoids are and inching and joining them medially and then going up and out, this is a nice alternative technique. The next thing I got to do is, after I've done the FUE tumescence, they are completely anesthetized in the back side. I've got to now anesthetize the frontal zone. So the frontal zone, after I've already given the nerve blocks, they should not feel very much of my ring block. So now I come back and join it with the ring block. The only area that probably will feel a little bit is right here, because it doesn't quite cover the nerve. So for a small distance, they're going to feel a little bit. So I use a 27 gauge to give some lidocaine there. I go ahead and harvest a few grafts. This is again FUE I'm talking about, as you see in the bottom left. And I harvest some, test the graft to site fit, and then I make my recipient sites. At the beginning, I like to do that. And then afterwards, I come back before my harvest and give bupivacaine nerve blocks that should last the entire day till the end of the day. And I come back and give a ring block as well. So here's a schematic. People like to get redundant information, so these are my little areas. I inject first with 1% lidocaine to 100,000 epinephrine with a 30-32 gauge needle, just to make the entries not painful. Then I just balloon these up. I raise these wheels. So the key information to take home for me is FUE anesthesia is not about ring blocks, it's not about nerve blocks, it's about field blocks. Dilute tumescence, and actually what's very interesting is dilute anesthesia can last much longer than concentrated anesthesia. And that's what's so mind-blowing with this, okay? So we're gonna do now the strip procedure and talk about that. You start with the same ring blocks. So I'm not going to go over that again. It's going to be the supraorbital block followed by the auriculotemporal, and then as needed, the zygomatic-temporal for a temporal point or lower portion. And then I'm going to go ahead and do the ring block. So in this case, remember, I'm not worried about the field block for a strip. I'm worried about a ring block. The ring block is going to get me the anesthesia I need so the patient is anesthetized. So I always start with the back, so that way their front is starting to settle and work with the ring block, the nerve block, as I come back. So I do the back with the ring block, and I finish with the front. And as an alternative, because you guys are not going to be under significant sedation, they may feel that 27 gauge going across. Again, you want their experience to be good. You can use breathable nitrous. You can also use remember that technique I showed you to block the entry so they don't feel it? I'll use a 30 to 32 gauge needle and just make little drops across there. So that way that 27 gauge needle, they don't feel it. Now, I don't need to do this because they're under intravenous sedation, but for you guys who are doing this that are not under that level of sedation, you should think about just staging the block. Progressive anesthesia is one of the principles we'll talk about in the summary, but this is critical. I occasionally like to use 4% articaine or septicaine. It provides a very profound anesthesia. It also allows for minimal discomfort during the anesthesia, and it lasts about 3.5–4 hours, so it's a great anesthetic. However, there is toxicity with the amount you put in, so there is a per kilogram toxicity. I have all that information I can show you at the end. Again, I really don't use the septicaine. I don't need it, but if you guys are looking for something to minimize discomfort, it helps. So after I finish this ring block around the head, I will then do tumescence. So for me, the donor tumescence is not so that they're numb. It does help. It's really to do a couple things that are so important, which we'll talk more about in a subsequent lecture. It's to minimize transection. It is to minimize neurovascular injury. It is to really, really take your time to get a flat, even, bloodless plane as you're doing the harvesting. So tumescence is critical, and I use the same technique as I showed you before. I can use using the spinal gauge needle. Remember, they're numb. They're not going to feel this needle. So I go in there and just let it fill up like a tank of gas. I love this technique. Is the technique I now use. But you guys, if they're still feeling it, definitely use a smaller gauge needle. But they shouldn't feel that. Then I score it with a multi-blade just so that I have the exact width. Again, a lot of this will be talked about in a subsequent lecture by me. And then I inject further. I can also use that spinal needle to inject as well. And so I give an additional anesthetic after the baseline tumescence is placed in, and after I've scored the dermis, I add additional anesthesia along the incision line to really minimize transection, make sure that area is hemostatic so that I can get a clean harvest. Transection is the #1 reason you get really bad wounds back there besides neurovascular injury. And I just do a very, very careful harvest. Again, all of the details of how I harvest will be actually given in a separate lecture. This is just the anesthesia. I do test the graft to site fit. And the reason I'm giving the whole overview is you want to get a context of how the anesthesia fits into the actual surgical flow. Then I go back and give a bupivacaine nerve block, and I give the bupivacaine ring block after that, and then I make my recipient sites after the graft site fit has been tested. Okay, let's talk about a few specialty comments here. So the next thing is beard harvesting. If you're doing FUE for this, obviously no one's doing a strip across the beard. So what I believe, the same thing. When you're looking at anything in the beard, whether it's a recipient area you're placing or a harvesting site you're doing, if you're doing facial types of either harvesting or transplant, the key to anesthesia is not a ring block. You're going to put too much toxicity, it won't last, and it won't be even. It is a field block. In other words, dilute tumescence across the beard for adequate anesthesia. So what I start with is that punctate point again, just so they don't feel the anesthetic, using a 30 or 32 gauge needle, gently injected and slowly. Once that is placed, I start the same thing that I showed you in the schematic before, which is basically a dilute bupivacaine, lidocaine combination, and just go slowly across this area. I use now my spinal needle to do it. I love it, but you guys can use, you can just use a regular needle. Now one pro tip here is that you may want to pump the bag up to about a green level when you're doing facial, because it does swell a little faster than the scalp, which is super tight. So with the scalp, I pump it up to full red. On the beard, I start with green, and then if I feel like I need more, I'll pump it a little bit up to the red. But I start with the green level with that tumescence. If they're feeling it, they're uncomfortable because you don't give the same level of anesthetic or sedation that I provide, back off. Don't just see that because I gave this lecture that you're going to use a spinal needle. It's a larger gauge needle, so if they're feeling it, back off, use a handheld tumescence. And remember, the smaller the syringe, the easier on the hand and the less pain for the patient. And what you can do, always practice safety with needles. If you're handing off back and forth, I always, you guys know this if you're surgeons, always hand it back to them where the needle's facing you so that they don't get stuck, okay? And teach them to hand it back to you so that you don't get actually stuck by handing these 3 cc's or 5 cc's back and forth very quickly. And you just progress accordingly. And you do the same thing if it's a recipient site or harvesting site on the face. You're gonna just start in one lateral point and go forward. I think I actually may show that. Okay, how do you anesthetize the central face? Basically just medial to, you're welcome to take photos of any of this stuff, just medial to the oral commissure. You're not gonna hit the oral commissure. You're gonna go just medial to it. What you wanna do is the rule 3-4-5. So what it is the 3 is the canine. So it's basically the third tooth over to the side where you're gonna inject it. The way you do it is you want to wiggle and shake like a dentist, inject at the unattached gingiva, and then turn your needle straight to the bone. All right, 90 degrees to the bone, and raise the bleb on the periosteum. Because the trick, though, is that as an ENT background facial plastic surgeon, we've been always taught to do infraorbital blocks. It's stupid, I hate to tell you. You want to do what's called a distal alveolar block. This is much more painful. It's not reliable to get the midline. If you guys are missing the midline, you're not doing a correct block. But what you want to do is you want to go unattached gingiva so they don't feel it, raise the bleb. I usually use carbocaine to start, then you'll see some slides up. I aim it down, I go straight to the periosteum. You can even go touching on bone, and then raise a bleb, okay? All you need to get a block is probably half a cc of any product, you'll get it. I do that on both sides. The lower side is much easier to anesthetize. You go to between the 4th and 5th roots from the midline instead of the 3rd off the midline. So just between the 4th and 5th roots, again, unattached gingiva, and then you aim to attach gingiva, you'll knock out that whole side. It's much easier to anesthetize the lower area, but once you get good at this, you'll knock this out every time. Occasionally, you're going to have some patients, they miss the midline, okay? You're not going to quite get the midline on this. And this is the stupid thing that I've seen a lot of surgeons do, because they don't give a crap about how the patient feels, which you should. They go right into the nasal alveolar, right in the midline. It hurts like crazy. What you do, if they have pain, is you start from the areas anesthetized. You know laterally they're anesthetized. You go into the unattached gingival area here, and you just slowly inch to midline with vibration techniques. And then when you're about to pass midline, a quick shake, go past midline, raise the bleb, they should be anesthetized, okay? So these are tricks. Again, you're welcome to ask me in lab. I'm gonna be floating this in lab this afternoon, so I'll be all around all the desks, you can ask me. So that's the trick. So what do I use? I use dental equipment. In fact, it was funny, I won Best Dentist, even though I'm not a dentist, because I bought, this is how crazy these stupid awards are, right? Because I bought dental instruments from a dental company. But carbocaine, 3% carbocaine is great because it doesn't burn. I use plain 3% carbocaine for my, what I call Preblock. So that quick anesthesia, I just put like a quarter carpule into each of those 4 quadrants. Then I put in what I want, whether it's bupivacaine, septicaine, which is also known as articaine, whatever gives me some lasting anesthesia. Remember, again, it stops medial to your oral commissure. You're not going to get the commissure block. And what's interesting is if you're doing beard transplants, the place they hurt the most is at the commissure. You've got to add additional anesthetic to make sure. So when you're giving that field block, sometimes I'll actually come back and give a direct full lidocaine or bupivacaine straight into the commissure, because this area is missed a little bit. It's a little uncomfortable for the patients. There must be a confluence of nerves there that are being missed. So go back and add a little bit of here before you start recipient sites in that area. So here it is, just alive. Here it is. I'm going in. I go unattached gingiva. It actually looks like it's on the border of both, but you're just going sort of up and out, because that way you can do sort of a quick shake, goes in, and then you want to aim it down 90 degrees right to the attached gingiva, right onto the bone to anesthetize it. To make sure it's anesthetized, I just shake, I rub it and shake it, okay? If you're a dental background, you probably think this is stupid because you know this already. If you're not, you probably are learning something. So showing you what I promised you is that it's the same technique for the beard donor. I start with a small bleb of lidocaine into one zone, and then I slowly raise these tumescent wheels. Just like this corner of the mouth is a little uncomfortable, this area also has a confluence of nerves. You're not going to get an effective nerve block in here, so you really want to do a really generous tumescence. Add a little bit more than you think you would need, because this area and this area are slightly more uncomfortable for the patient. Eyebrow transplants. I'll be giving a lecture on this tomorrow, but just for sake of completeness, I'm talking about this area. So what I do for the eyebrow is I want, because it takes us about a half a day to complete an eyebrow, maybe a little bit longer than that. So for me, the septicaine works really well because it doesn't burn as much, and it allows me to have a very profound anesthetic with very low volumes. The nice thing with articaine or septicaine is it provides very little discomfort, long-lasting anesthesia, not as long as bupivacaine. Very little burn, and for very small quantities, it provides a very robust zone of anesthesia, better than lidocaine does. So I first do a supraorbital block. I just go in there and put a little supraorbital block. At this point, I'll actually come out of the foramen. I come up medially superficially and just hit the supratrochlear block as well. So I will do a little supratrochlear, and then I will anesthetize across that area. To minimize the anesthetic load and the risk of smearing my lines, I usually go outside my line and just inject so I don't smear the lines. You want to be really careful not to smear the lines. And then laterally, to get that lacrimal branch, you're not going to get a reasonable nerve block on the lacrimal branch. So I just do a direct infiltration laterally on the nerve. So that's just showing you how I do it. I sometimes go outside my line so I have a less risk of a problem. I oftentimes will use our friend Alexa to help remind me about anesthetic times, like, hey, Alexa, remind me at 10:15 a.m. to add bupivacaine or whatever it may be, so that I'm keeping track of things. So the summary here is gate theory of pain. So the idea of this is that vibration really helps. Now, I have actually mastered a technique where I'm able to shake my left hand side to side while injecting forward with my right hand slowly. It's like tapping, rubbing your belly and tapping your head. It's a little hard to do, and you definitely don't want to stick yourself. If you guys want to learn how to do this, I will show you this in lab. But you can actually increase pain for a patient if you don't get this right, because the natural tendency is to shake violently with your left hand and jab it with your right hand. You need to coordinate the two movements. And that makes, to me, I can control 90% of the pain through my fingers, not the vibration device. So it's a really cool technique. I show this in the new book that Ken and I are working on, and we don't make any money off it. It goes all to charity, just so you know that. So there's no financial interest in my mentioning it. Sedation, whatever you can do. We have a fully Joint Commission accredited facility. If you can get accreditation, to me it's worth it. It makes the patient experience insanely better. Progressive anesthesia, you've heard this. Start from an area and move away from those regional nerves so that you can minimize discomfort. And know how to leverage nerve blocks, ring blocks, and field blocks. And the summary again, for anterior anesthesia, to provide profound, consistent anesthesia, I do not rely on my ring block. I use my ring block as an ancillary support. I use my nerve blocks for profound, consistent, full-day anesthesia. I use my ring blocks to provide additional anesthesia and also hemostasis in the anterior portion. So this is about nerve and ring blocks. The recipient tumescence doesn't add much anesthetic. It's just for hemostasis and to minimize neurovascular injury. The FUE back, the summary, is all about a field block. FUT, it's all about a ring block, but I use the tumescence to minimize transection and neurovascular injury. For anything in the beard, it's all about the field block. So as a president of the American Board of Hair Restoration Surgery this year, I really encourage you, as you start to get more senior in your field, to join us and have fun. We're going to have a great time in Lisbon with this. So thank you for your attention. We have some time for questions.